Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel, and today we're going to be talking about Polycystic Ovarian Syndrome. My guest today is Dr. Disha Narang. Dr. Narang is a leading endocrinologist, obesity and culinary medicine specialist, and director of obesity medicine at Endeavor Health System in Chicago. She graduated with her medical degree from Vanderbilt University School of Medicine and completed her residency and endocrinology fellowship at the University of Chicago. She has been featured in numerous media outlets, including BBC, CNN, Wall Street Journal, and NPR, speaking on the obesity epidemic, diabetes, chronic medical weight management, and our food environment. Dr. Narang also especially enjoys working with women at all stages of their lives and families navigating obesity and chronic disease. So welcome, Disha. How are you?
Thanks for having me.
Nice to have you. So I think we both know Disha
Yes.
Patel, my first guest for the second season. So I think that's how we met. I'm so excited to have you on. How do you work together? Do you still work together?
We became friends, I think, like 5 years ago now, and we literally met via social media. And it's one of those things like, sister from another mister type of thing. And we've become the best of friends. And, we've seen our careers sort of go in this direction where we really emphasize, weight management, obesity medicine, culinary medicine. And, I love women supporting women. And, she's doing her thing in San Francisco and I'm in Chicago. But I think each of us has shaped so much the way that our careers have unfolded in the last several years. And truly, we just met on social media and we are as close as can be. So
do you also work together?
We've collaborated a lot on various projects and initiatives and so the nice thing is about the virtual age, there's so much that you can still do from a collaborative process, even when you're at different sides of the country. And so, so much of it is like learning together, growing together, and with that, we've even grown further in terms of close colleagues that, practice obesity medicine and like-minded folks that really, get together and learn from one another. And so, the internet's cool in that way. Social media can be really a blessing, of course. Obviously, it has its negative parts of it as well. But in with respect to us, like it's been a really positive experience because this is how our network has grown. This is how we've met like-minded colleagues. This is how there's not that many obesity specialists nationally, right? And especially when you look at like culinary medicine and some of the, the ways that we practice, there's not that many of us. And so I think it's been a really, really fun and valuable friendship.
Yeah, well, I definitely agree with how the internet, that's how I know you two. I'm on the East Coast. So really we're bringing the whole country together this way. But yes, I've gotten to meet so many great people online and now it's really fun being able to feature you on this podcast.
Yeah.
And so I'd like to start the episode by learning a little bit more about my guest. And I think in Nisha's case, she kind of shared how she got into one of the things I thought was really interesting was, like you said, culinary medicine is just kind of something new. And I haven't heard of a lot of people practicing that. Yeah. So I guess if you can share, your journey, how you got into doing what you're doing, that would be great.
Well, so I'm fellowship trained in endocrinology. And so, so much of what I do is diabetes management, and endocrinology, it very much lends itself to obesity medicine as well. Because obesity, weight gain, weight loss, so much of it is hormonally mediated. And so a lot of my time as a physician is actually spent talking to people about what they eat. And it really has changed the way that I work with my patients who have diabetes and obesity. And I think that one of the things I've noticed over the years is that one of the biggest questions people have, and it doesn't matter, where you come from, what your background is, but it's, hey, what do I eat to get healthy, right? How do I put it together? How do I create sort of a dietary pattern to kind of, make my disease pattern a little bit more stable. And so it's something that people are really intimidated by. And I think that there's just so much disinformation in, social media and just everywhere. Like, well, what diet should I be on? What, I was told to do keto, or I was told do this diet or that diet. And, and the thing is, like, there is no diet. Like, if it was that easy, we would have figured out diabetes, obesity, all of these disease processes. But one of the things is that how do we navigate our food environments that to make sure that what we eat is conducive towards better long-term health? And so, again, I always say it's never too late to start doing that. And the thing is, like, when we work with one patient or one person, maybe that affects their children, maybe that affects their partner, or maybe that affects like their bigger family. And I think that there is a bit of, a ripple effect there. And a lot of the time, just because it's sort of, stereotypical / traditional, women are often the nutrition gatekeepers of their family as well. Right. And so they're the moms that are going to the grocery store, or they're, planning the meals or whatever. And it could, there's obviously several different family members that could be doing that. A lot of the time, though, it is women. And there's a lot of, confusion, sometimes even fear of the grocery store, like, how do I put these ingredients together? What do I do with these veggies? Or, or I don't like vegetables. I don't want to eat that, that sort of thing. And so part of it is breaking it down, allowing people to have the tools that they need for their lifestyle and their resources to still, be able to create a healthier dietary pattern. And so does that mean, picking up a rotisserie chicken versus the fried chicken, and combining that with some roasted veggies or something like that for like an easy weeknight meal? Does that mean that we are, repurposing that to put on salad the next day at lunch? Does it mean that we are more mindful about making sure that we are, buying some extra Greek yogurt so that we have breakfast on the table every day and a higher protein option? So it doesn't mean that you have to become a gourmet chef, but so much of it is just sort of that mindfulness that, like, okay, I'm going to actively reduce the amount of processed food in my life and, actively plan towards being more mindful towards what I eat. And just some of these minor changes can literally change the outcome of someone's, weight trajectory, their diabetes trajectory, but that also extends towards PCOS or high blood pressure or heart disease or any of those things. And so, again, none of it is about being a gourmet chef, but we live in an obesogenic world, right? So everywhere we turn, there's a fast food restaurant on every corner. There's convenience stores. There's all this stuff. And so we live in an environment of convenience that is highly conducive towards gaining weight. And that's what we are trying to, at least make a dent in, right? Like by 2030, 50% of our population is expected to have a BMI above 30. And that's class 1 obesity.
Yeah, no, I mean, you're leading right into why I wanted to bring this up, because, we share patients as a gynecologist and endocrinologist. This category, patient polycystic ovarian syndrome patients, are patients we share, and the rates, it's super common. It's up to 10% of women can be affected now, and we're seeing this more and more. And the reason we're seeing it more and more is because it is related to all of these conditions that you're talking about: obesity, metabolic disease, right? Type 2 diabetes. So I thought we'd start with, thank you for sharing that perspective. And I thought we'd start by talking about, what PCOS is, because I do think, I'm time limited in the office, and it is, this requires a long discussion. It's actually a lot more information that patients need about this than the 15-minute appointment, and I think it's confusing. The name polycystic ovarian syndrome makes it sound like it's about cysts and the cysts are causing problems, but that's not what it is, right? So, this is actually really fun for me because, I talk about PCOS all day long with patients from my gynecology perspective, and I give them a touch of the medical perspective and what they need to do next, maybe working with their primary care or if I refer them to an endocrinologist or a dietitian. But I never get to sit down and talk with, I've never sat down for an hour and talked about polycystic ovary syndrome with an endocrinologist. So I think this is going to be fun for me too.
And honestly, I don't think I've been able to sit down with a gynecologist to do that either. So I love this.
It's truly a syndrome affecting your entire body on multiple organ systems. And so it's just not right to just, one doctor isn't going to be able to help you with this. You may need multiple doctors, team. Yeah. So, where would you like to start? I guess what is PCOS? We could start with that and I can add thoughts or I can start whatever you like.
So, PCOS, there's a couple different ways to describe the disease. So it's actually a clinical diagnosis and it's not just that you have cystic ovaries. So there's a couple different things that we look at, and that's called the Rotterdam criteria. And what that means is that you may or may not have cysts on your ovaries per ultrasound. You might have what we call androgenic symptoms, which means increased acne, facial hair growth, or hair growth on your chest, stomach, back, that sort of thing. Or you might have hair loss on the head. And then a lot of people come in with irregular periods. So that's a common, presenting complaint because people don't automatically know that they might have cysts on their ovaries. But many, especially younger women, come in, just having irregular periods for years, for example, or they might get diagnosed as teenagers because, into high school, they suddenly don't have regular periods anymore and they used to before, or they always had irregular periods. And so it's typically that conglomeration of those three basic things like irregular periods, androgenic symptoms, and cystic ovaries. And again, it's not based on labs, it's not based on imaging, it's a clinical diagnosis. And so it really depends on sort of the whole picture, as we were saying before, right? It's not just like, oh, you have cystic ovaries, so you must have PCOS. That could be due to other things, as you know, as well. But we have to sort of look at the whole picture. And PCOS in general is a disease of insulin resistance. And so that directly ties into, the increase of diabetes in this world, the increase of obesity, because those two things are a process of insulin resistance as well, right? So kind of in short, it's a clinical diagnosis, and it's important to sort of, again, look at the whole patient versus just one aspect, whether it's their labs or imaging.
Right. And I kind of like to explain to patients that it's a little bit more of it's more of like an endocrine disorder, right? Because it starts with that, like the insulin resistance, something will trigger it. And then that leads to, the androgen levels going up, the testosterone levels going up, and the, inhibiting your ovulation. And then when you inhibit ovulation, that's when you miss your periods, right? So, because I think that can be very confusing for patients, and there's often a trigger, right? Like that's what I found is, I don't know, like the pandemic, for example, caused people to become maybe sedentary and put on some weight, and they may have some genetic predisposition, and then maybe putting on some weight suddenly made them more insulin resistant and then exhibit these signs of PCOS. So sometimes I see that, sometimes I don't. And so I think, I find that kind of something important to explain, that we can't just reverse it. There's no medication to, fix it. So what's like
better? And the one other thing that I want to also point out is that PCOS may not always look like what we're saying either, right? Like someone might not have the acne and facial hair growth. They might not have had weight gain. You could have a perfectly normal weight as well and still be diagnosed with PCOS. And so there's different ways that it presents, which also can make it, overwhelming for patients. It can make it confusing as well, because this is a common question that I get. Like, well, I haven't gained any weight. Well, but the thing is, like, you could still have that whole kind of irregular periods and cystic ovary, all of that still sort of fits into the diagnosis of what PCOS is. And so there isn't necessarily a strict look that someone has to have that diagnosis.
Right. That's such a good point because, okay, so I'll say the most common reason that I'll end up seeing or diagnosing a patient with this is period issues, right? And
definitely.
what are those period issues? Often it's skipping periods or not having a period at all. But sometimes if this has been going on for a while, it can also be irregular periods because you can have periods, but if you're not regularly having a period, sometimes there's buildup in the uterus and you can have you can have irregular bleeding. And so that can be very confusing. So any period issues are I'd say the number one reason. But to your point, yeah, I've had patients with no other symptoms other than complaining of increased hair growth, for example. And that's prompted me to do labs. And then that led to the diagnosis. So
it's a spectrum, right? So I guess if not diagnosed early enough, then some of those other symptoms could develop. Or, exactly like that person might just present with increased acne and that's how they get diagnosed. Or they might come in with, oh, I've had some hair loss on my head and that's how they get diagnosed. So it doesn't always have to be that irregular period complaint as well,
right.
To be diagnosed. And then actually from an OB-GYN's perspective, I would love for you to also talk about like what defines an irregular period, because some people think that it's irregular if they go months without a period, obviously, but then others might think that it's irregular if it's like a 35-day cycle versus a 28-day cycle. Like how do you define that? I actually, even for me, I would love to learn that.
I like to say approximately a month. It doesn't have to be exactly, like 28 to 35 days, but approximately, and you don't have to have the exact same interval every single month, right? I'd say, what tends to prompt us to doing the workup, I guess that's how I'll define it, is if you're missing, say, if you have amenorrhea, which is no period at all, okay? Either primary amenorrhea, which is just never getting your first period, or you get your first period, but then for some reason at some point it stops and then you never get it back, or you're not getting it back. Or oligomenorrhea, which is irregular cycles, less than, say, 9 periods a year. Okay. So that interval can vary, because like you said, it is a spectrum, right? So you can have, and I'll tell patients this, you can have a touch of it and you can have full blown PCOS. It's like diabetes in that you can have, pre-diabetes to full-blown diabetes.
Yeah.
Right.
Okay. That's helpful because that's a very significant point of confusion, at least that I see, for patients who are coming in for PCOS.
Yeah. Sometimes they come in and I'm like, no, your cycles are actually pretty normal. Exactly, I wouldn't worry about it. But I've diagnosed PCOS in patients with normal cycles, like that patient I had with the hirsutism, and that's hard too. That's a hard symptom because
that can be ethnic, like
yes,
right? Like this is a common,
yes, like Middle Eastern, Mediterranean, South Asian women. We can have
hair,
a dark, thick hair that in certain areas that may make some clinicians think that it's abnormal. And my rule of thumb is, well, does the patient think it's abnormal? Because because you'll know
if all their family members have the same issue, right? And so that's actually one of the number one questions I ask patients. Well, what is your ethnic background? And that also kind of helps understand the history a little bit better, because if you're getting that kind of hair growth, having, like an Eastern European or European background versus, maybe you're South Asian or something, I think about it completely different in those situations,
Yes. And actually that reminds me, we should talk about, so, the insulin resistance leading to the high androgens, the like elevated testosterone or dehydroepiandrosterone. I'm probably pronouncing it wrong. DHEAS. Well, anyway, that the symptoms that causes can be acne, increased thick, increased hair growth in a male sort of pattern. So facial, like chin, chest, lower abdomen. Oh yeah, you mentioned that earlier. Right.
Yeah, between the thighs. Yeah, those are, and then hair loss on the head too.
Right. Yeah. And so you just need the 2 out of the 3 Rotterdam criteria, like you said. I see lots of people with normal looking ovaries on ultrasound, you know, so.
And that's why it's important to make sure that we emphasize this is a clinical diagnosis. So even labs may actually also be normal, right? Like test levels might be completely normal, other hormone levels might be completely normal, but I often still diagnose PCOS because people meet that criteria of having those sorts of androgenic symptoms in addition to irregular periods. And so that's why it kind of makes it a confusing diagnosis, because it's
the other thing that you reminded me of is, it can also be other things. Like when patients come to me with irregular periods, I'm doing a hormone panel that includes PCOS testing, but it's not just, definitely PCOS. Some, other tests I'm doing are like a thyroid test or prolactin level, because other hormonal problems can also cause this.
So the other thing to think about, so we want to make sure that we're ruling out a pituitary issue so high prolactin can cause irregular periods. Exactly. Like uncontrolled thyroid levels can cause that. But the other couple things that we check for are congenital adrenal hyperplasia, again, very rare, and then Cushing's disease as well. And so some of these things, they're much more rare than obviously PCOS, but we've surprised ourselves. And that's why it is important to do that full panel of labs if somebody is coming in with, those complaints. And that's for especially the testing for like the congenital adrenal hyperplasia or Cushing's, that's something that I often do. And so that's something that, an endocrinologist would be very comfortable ordering. But it's so important to make sure that we're not just like, tunnel vision, yes, it's PCOS. It could be so many different things.
How often are you how are patients coming to you? Are they referrals from the gynecologist, the primary care? Are they coming independently, or they have diabetes and then they?
Yeah, all of the above, honestly. And so, of course, yes, they might have diabetes. They may be, referred to me for obesity management because that's, I'm an obesity medicine specialist. They might be coming in for irregular periods, or gynecology is sending them, or vice versa. I see them for irregular periods and then I send them to gynecology, right? And so there's so much sort of it's an interdisciplinary disease process, right? And so it is important for us to be on the same page, because again, it does require a bit of a team approach. So for example, if that means that patient, I've had this often actually, like we'll get to the treatment, I'm sure soon, but I often send patients to gynecology when patients say like, oh, well, I can't tolerate birth control pills, for example. And so, then that's something to, prompt me to say, okay, well, then I think you need a conversation with your gynecologist to figure out what's the best way to manage your hormone levels and get your periods back on track, for example. But that we can of course talk about treatment separately, but that's why there's so much back and forth between our specialties. But yes, I kind of get patients from all over for this.
So, and I'm kind of curious, I'm just curious, how often are you seeing some of these rare conditions? Like I'll order some of the labs and then I'm like, I've never seen an abnormal. But you're probably seeing a lot more than me.
I mean, even then, something like congenital adrenal hyperplasia or Cushing's is exceedingly rare. And so, I've been doing this for almost a decade. I've probably diagnosed 2 or 3 Cushing's cases, maybe 4 if I'm stretching it. So it's very, very rare. CAH, which is again, it's congenital adrenal hyperplasia. A lot of the times this is often diagnosed in childhood, because patients might have ambiguous genitalia, or some patients might have normal looking genitalia, but then they present later in their teenage years because they might not get a period, or again, the periods are super irregular. But because I treat adults, the CAH that diagnosis may have already been made by like pediatric endocrinology or the patient's pediatrician. So that's again, not a common diagnosis that I make anyway, but we test for it just in case, because there certainly have been missed cases. And then prolactin we see fairly often.
Yeah, I see that one. Yeah.
Yeah. So that's something that we see often. But then again, like prolactin, is it pituitary related? Is it because of medications somebody might take? Like, so we need to kind of parse through that as well to figure out, well, okay, if you do have an elevated prolactin, why is that? And then, of course, then you've got sort of, I would say, the run of the mill kind of PCOS, like you have your elevated testosterone on labs and, that kind of that classic like lab picture. But then again, that doesn't always happen either. And so I think it's really, really important to make sure that we are thinking out of the box on this one. And then at the end of the day, once we rule everything out, then I go back to PCOS, because you don't want to just hang your hat on that one diagnosis. Yeah.
Okay. Now I'm going to ask another question just for me, which I don't know. I do think I have some med students listening to me or other doctors, So, like at what point, would you do further workup for like an elevated testosterone or DHEAS level, where it's so high that you assume that you think, oh, it could be something more serious.
With PCOS, it's kind of high, right? Or like it's still kind of in the upper end of normal / like above the normal. But when it's like 2-3 times the normal value, that's when you start thinking about, okay, is this like an adrenal tumor or like an ovarian tumor or something like that?
Okay.
Even this is obviously not PCOS related, but in older women, there's like hyperthecosis, right? And so that's when older women have a sudden increase in testosterone production. And that's, from the ovary. And so that's something that, they present obviously with like increased hair growth and things like that. But there's different reasons for high testosterone levels in all different ages of women. It also depends on how high that testosterone level is as well, right? And so if it's not super high, but kind of high, then more likely than not, yes, it's probably PCOS. But if it's extremely elevated, then we've got to figure out, well, why is that? Yeah.
Okay, thank you. That's helpful for me for every day. So the other thing, a common question I get is, why me? Why is this happening to me? And we don't have a good answer. This is what I end up saying is we don't have a good answer, but you can look to your family and ask some questions. Are there women? There's probably some genetic link. Like, are there women who had period irregularities or, fertility issues or type 2 diabetes or just any family member with type 2 diabetes. So is there anything else you can add to that or?
Again, it's nobody's fault. It's not like someone's doing something to make themselves get PCOS, right? A lot of this, yes, it certainly can run in families, but where I always say like, well, what do we have control over versus what do we not have control over? Right. And so the number one thing that I look to is like, okay, well, what does your day-to-day lifestyle look like? Right. Let's say if they're, somebody's eating out a couple times a week, multiple times a week. Well, how do we start cutting back on like processed food intake so that you are eating, less processed food, more fresh food, that sort of thing? Because again, as I mentioned, we live in an obesogenic environment. So even if your weight is normal, you still, if there is a high intake of processed foods, I don't know. I mean, there's more endocrine disruptors out there now. We don't know. We don't have research on that though, right? So I can't necessarily comment like facts there, but certainly, yes, like this is happening more and more, but obesity is also a bigger concern these days. And again, even when we don't have obesity in the patient, what does their food environment look like, right? Or what does their movement look like? And, potentially that's almost like a little bit of a silver lining, because if the patient's diagnosed earlier in life, well, we can target like treatment earlier in life as well. Maybe we change the course of their life and prevent something like diabetes or heart disease or high blood pressure or something like that, because we change the way that somebody was eating, or I don't know, their emphasis on exercise or whatnot, like early on, or maybe we set the stage for a healthier pregnancy and postpartum metabolic, like, picture as well. So it's not, again, like we're not pointing fingers here, but if it means that we can make any minor tweaks in someone's day-to-day to affect these long-term issues, that's where preventive medicine becomes like a thing, right?
Yeah. I love a couple points. I was going to ask you about what you thought of endocrine disruptors. So thank you for that. Because yeah, you make a couple of great points, like, I mean, PCOS is increasing. Why is that? And I love that term, that we live in an obesogenic environment. Yeah, it isn't anyone's fault that our society is like this, but unfortunately we have to be proactive and, yeah, protect ourselves, and especially now with, I don't know, I've heard some environmental changes are happening and they may be allowing more dumping of chemicals. And like you said, we don't know enough about these endocrine disruptors. And so that may increase our risk further. So we have to
an active area of research. And so this is all just conjecture, right?
Right.
Is that also affecting fertility rates? Like infertility is sort of at an all-time high as well. And so we just don't know, right? And so again, like what is in our control versus what's not, right? Like, does that mean that we decrease, I don't know, our use of plastic wrapped things or, plastic bottles or I don't know, right? Or we just don't know.
We don't know enough, and right? And I mean, but the food problem in itself is huge, right? The food environment that we live in. So,
Absolutely.
So I guess that brings me to, obviously, well, and maybe before we go talk about how to treat, I guess another thing I wanted to bring up is just the risks, the future risks that I think another thing patients need to know about why we need to manage PCOS, right? Because from my perspective as gynecologist, yes, it can cause infertility. Basically, and the way I like to explain it is infertility because you're just ovulating less, right? If you're ovulating less, those are less opportunities to get pregnant. So it's actually not as hard to treat as some other unexplained infertility, for example. And then another risk, speaking as a gynecologist, is these patients have a higher risk of developing endometrial cancer. So those are my primary concerns. I know patients' primary concerns, and also my concerns are their symptoms, which are really annoying, like unpredictable periods or acne or hair growth and, struggles with their weight. But these are two other things that are more hidden. They may not be thinking about, right? Yeah. And that as far as the increased risk of uterine cancer, I like to explain that as well. You're not shedding the lining regularly. Sometimes you're not building up the lining to shed, and that's less risky, but sometimes you still have circulating estrogen. It can also come from, the fat cells in your body, and that builds up the uterine lining. And then you don't get the ovulation signal to then shift the hormones and shed the lining, which would prevent the buildup that can then lead to like polyps and precancers. So, but I want to talk about the other long-term risks for PCOS patients, because it's not just that, it's also medical things.
Yeah, I mean, but I often am thinking about that as well, because I think sometimes, it's sometimes convenient not to have a period every month, right? And so we have ways of obviously making that happen medically, but not being able to shed that endometrial lining does carry that increased risk of endometrial cancer, of course. And so that's a common conversation that I have in clinic to explain, like, this is why we care, right? But from my end, especially from the endocrine end, we're looking at it from a metabolic perspective, because does that mean that you suddenly have an increased risk of diabetes? Or do you have an increased risk of having gestational diabetes, during your pregnancy, whenever you may get pregnant? Does that mean that you have an increased risk of heart, like high blood pressure, cholesterol, that sort of thing? And that directly correlates to increased risk of cardiovascular disease or heart attack later in life. So those are the things that, like, I think about. And that's why we do turn to weight management a lot of the time, right? And so when we lose weight, our insulin sensitivity goes up and our insulin resistance goes down. When we build muscle, that's what happens as well. Our insulin sensitivity goes up, our insulin resistance goes down. We use up those fat stores, obviously, but also your body metabolizes what you eat in a much more efficient manner. And again, not all PCOS patients look the same, but if that means that we are starting to cut back on processed food intake and like that sort of thing, that's never a bad idea, right? But then, as women age into their 40s and beyond, into perimenopause, menopause, cardiovascular disease is the number one killer of women in menopause, right? So if we have the ability to address this earlier in life, not that PCOS is directly tied to cardiovascular disease, but mitigating those risks do potentially decrease the risk of heart attack later, right? And so what that means then is that we get to extend your life. We get to hopefully improve your quality of life. If weight is something that you've struggled with, then hopefully we can help. We have so many resources and treatments and things like that to help with that. Does that mean that potentially you have a healthier pregnancy and a healthier time postpartum, returning to your desired weight? Is your functionality better, right? Even this like lifestyle stuff, is like your libido appropriate? Is your like all these things, right? And so this is a comprehensive set of questions, a comprehensive set of issues that we have to address. And it doesn't just come down to like, we just need to regulate your periods. Yes, that's part of it, but there's just so much more.
Yes. And thanks for mentioning, of course, gestational diabetes is a big one that, OBGYNs have to deal with. And, you also reminded me, I've been reading more and more about how, patients with PCOS have a higher risk of having anxiety and depression, mental health issues, and even eating disorders. So actually, my next question for you is like, how often do you screen for diabetes when you have a patient like this? How often should I be screening, doing their lipid panel, I guess I do tend to defer if they have a primary care provider, but if they don't and they haven't been up to date, then I'm kind of curious about.
A lot of women are, utilizing their OBGYNs as sort of their primary care. And so I think
there's a shortage of everybody. So whoever you can get, right?
Yeah, and it's true. And I definitely sympathize with that as well. But I would do at least a yearly lipid panel, depending on family history, definitely a yearly A1C check for diabetes, if not twice a year. But the other ways to diagnose diabetes is, of course, the oral glucose tolerance test, which you all do often in gynecology, or the patient needs to have 2 fasting blood sugars 3 months apart, or at least like several weeks apart at 2 separate times above a fasting of 126, or a random blood sugar during the day above 200. So there's a few different ways of diagnosing diabetes, but insulin resistance is a real thing. Some physicians do choose to check insulin levels as well. I will do that intermittently, but I don't think that necessarily changes my management, because I kind of know already that they're insulin resistant, they have high insulin levels. So I don't think checking that lab necessarily changes anything. It still kind of goes back to like, okay, well, we have to focus on weight loss, like, dietary pattern and that sort of thing. And so, and so those, in terms of like metabolic, you want to rule out fatty liver disease as well. That's a big one. And so you want to check liver kidney function, of course. And then the other big thing is screen for sleep disorders. Like there's a lot of correlation between sleep apnea and PCOS as well. And most patients with sleep apnea often go undiagnosed, right? And so that's a big one, because, and oftentimes in the setting of undiagnosed sleep apnea, people have a lot of difficulty getting weight off as well. And that is one of those screenings that I probably will do on most patients, because everyone's tired, right? Well, why is that? Do you get like 3 hours of sleep, or is it because you snore all night? Or like, is it, we got to get to the bottom of this like chronic fatigue everybody is feeling. And not that everybody has sleep apnea, but if it's not your hormone.
We don't talk about it enough, actually. I'm in the middle, you may have read it, but I'm in the middle of reading Breathe, that book. Have you heard of that book?
I have.
It's really interesting, because I didn't really realize, respiratory disorders can also cause, I guess, it's all linked. Increased risk of cardiometabolic disease and high blood pressure, things like that. So, so I think that's really a good point to mention sleep apnea. I think it's a lot more common than we diagnose.
So common. Yeah.
So now we can talk about treatment, and I think I do think that it is maybe at first disappointing to hear, there isn't really like a magic cure, right? And it is the number one treatment is diet and exercise, right? And I guess I do want to mention again that not every patient really has weight to lose even. I definitely see normal BMI patients with this disorder, but we can still all be healthier. And right. So So, and from my point of view, I tend to, defer to the dietitian or primary care, but are there any guidelines or principles or diets or anything? I mean, I guess you mentioned earlier you don't really have a specific diet you recommend.
Yeah, there really isn't a specific diet. I think, again, we want to make sure that we are limiting, the processed foods, refined carbs, that sort of thing, that sort of thing. And so one thing that I often say is like, not all carbs are created equal. So like a cupcake is not the same as brown rice, right? Or a cupcake is not the same as an apple. And so we need to kind of differentiate what we mean by like, oh, I'm going to cut my carbs. Like, well, why would you cut out eating like healthy fruit? Or why would you cut out eating quinoa or brown rice or something like that? And so, going keto, for example, is definitely not a recommendation because, again, like you need to figure out what's going to be sustainable long term. So if you can picture yourself eating in a certain way, 25 years from now, then great. But if you think, okay, I'm only going to be able to do this for a month and then go back to just, some other dietary pattern, well, then that's not the one for you. Right. And so you have to figure out like what is sustainable, what's going to keep me satisfied, what's going to keep me feeling good, et cetera. And then, in terms of like treatment, like we do have medications to help mitigate the side effects or like the effects of PCOS. So of course, for the irregular periods, if it was like a typical, treatment, it would be the combination of a birth control pill, potentially spironolactone to help with the acne and the hair growth, and then potentially metformin because metformin helps with the insulin resistance, and metformin can also help with somewhat like of cycle regulation. However, I would actually love to get your input on, the birth control part of it, because I've had patients come in complaining about birth control made me gain weight, right? Or I get headaches, or I feel terrible on birth control pills, or, just a whole host. I'm sure you've heard of so many different issues.
Yes.
So I would love to.
I have some more questions about that for you too. This is the part I was kind of excited about. So yeah, I mean, I try to explain to patients that unfortunately the treatment is more of a medical treatment, like diet and exercise, to try to get to your, optimal health. Sometimes if you have weight to lose, not everyone does, then sometimes even like a few pounds different, down can change everything with symptoms and even getting your periods back and increasing your fertility, so that's
I think,
great.
In this world of weight management, obviously like things are so different now than they were like even, 6 to 8 years ago, because now we have approval for, these injectable weight management agents. We've had the oral agents for many years, and then the injectable agents we've used for 20 years now in the world of diabetes. But the weight loss is, especially for those who potentially may have a history of obesity, that weight loss could be the game changer to having regular cycles again. And we've seen this, and it's amazing how patients' lives change because, one, they feel more confident. They feel like, oh, like I feel normal again, like, that sort of thing. And so I love watching that transition. That's my favorite.
Yes. I love that's what I will go to talking about the birth control, but I actually want to ask you about that. Like, since we're talking about this, yes, I have had patients on metformin, and it's not really, we don't really prescribe metformin to cause weight loss to get your periods back. That's not how it works. But I have had patients prescribed on metformin who do end up doing just that, get their periods back and then get pregnant, but that's not really the path that we follow. And I guess I wanted to ask you that, like, if you've been using these newer meds on, and I guess, you're sharing that you are, but how do you decide what to start with? Is it more based on their medical status otherwise, like other medical issues? Yeah. It's not just for PCOS or
all of the above, right? So the per guidelines, patients who have a BMI above 27 with a weight-related comorbidity, and so that could include something like BMI of 27 plus high blood pressure, cholesterol, potentially fatty liver disease, diabetes, sleep apnea, heart disease, any of those kinds of things are considered a weight-related comorbidity. Or a patient with a BMI above 30 with no other comorbidity would be eligible for a weight management medication.
Okay.
We've used oral agents that are FDA approved for many, many years, if not decades at this point. And so, for some patients, that might be a good, option as well. So something like a combination of bupropion and naltrexone, which is branded as Contrave, that can help decrease the food noise or cravings in patients. Then we have another medication that's a combination of phentermine and topiramate, which is called Kisimia as the combination pill. And that also can aid with up to 10 to 12% excess body weight loss. Some patients who might not necessarily be good candidates for the oral medications are those who have uncontrolled blood pressure issues, those who might have a history of kidney stones, and those who might have a history of glaucoma. Some people can have, palpitations or tremors on Kisimia, for example. They might have sleep changes, that sort of thing. But I would say by and by, most patients tend to be safe candidates. Now, and then obviously in the last several years, the GLP-1 injectable agents were approved by the FDA for weight management. So initially they were approved for the management of diabetes. And in the last 6 to 8 years, we've had approval for weight management without diabetes. And so again, same criteria, BMI above 27 with a comorbidity or 30 without any other comorbidity. But a percentage of weight loss is upwards of 15 up to like 22% on the injectable agents. And so they're weekly injectables. Succent is a daily injectable. And so I oftentimes though, the rate limiting step these days is cost insurance coverage.
Right.
And so that's been, a tough landscape. We've dealt now with shortages for the last several years. Now these medications are no longer in shortage. So that's good news. But what we're dealing with right now is insurance denials. And so it's really important from a patient's perspective to figure out, well, what does my insurance cover? At least in our area in Chicago, about 50% or more of employers have coverage for these agents. So you may be pleasantly surprised if you're eligible that you might actually have coverage. I also do think that in the next couple years, the prices are going to start to drop as well. The prices have already dropped. Now, it dropped from like the 600 range to the 500 range. So it's still very pricey, but it's still going in the right direction, which is promising. We also have many more agents in the pipeline as well, which is really exciting, which I hope that will drive down costs and also allow for increased options as well. So right now, the two main weekly agents are Wegovy, which is semaglutide. That's a GLP-1 receptor agonist. And then tirzepatide, which is Zepbound, is GIP plus GLP-1. Tirzepatide has a few more percentage points of weight loss compared to Wegovy. Tirzepatide is also approved for patients who have sleep apnea as well. And so if the patient has a history of sleep apnea plus obesity, they have, they're FDA approved for something like Zepbound. But again, it often depends on insurance coverage. And then Wegovy is approved also not only for weight management, but for patients who've had a prior history of heart attack, stroke, or a peripheral arterial disease. And so the data is obviously very promising from a cardiovascular standpoint. And then, the sleep apnea, and we have much more data, I think, in the pipeline as well. But, these have also been game changers in our PCOS population.
Right.
I can't wait to see the day when we have FDA approval for PCOS, but it's not FDA approved just yet.
Okay. Yeah. It sounds like if they meet one of these other criteria, they may qualify anyway, and it would help their PCOS.
For sure.
So, okay. So to answer your question about the birth control. So, we have to establish with the patient what their goals are, right? Like if someone is coming in with symptoms of PCOS and is diagnosed with PCOS, my next question is going to be, I'm then looking at their age and their fertility goals. Are they trying to get pregnant or plan to get pregnant? Or do they need birth control? Because if they need birth control, then it's a no-brainer to recommend birth control. So basically what we're trying to do, why do gynecologists recommend the pill so much, right? For PCOS? Because I think sometimes I get, the kind of questions from patients like that and resistance because, won't the pill make me gain more weight, right? Well, it's true. The pill is not prescribed to help you lose weight, but you can lose weight while taking the pill. We can also prescribe a lower dose pill. The pill is prescribed to manage your symptoms, right? The pill helps with decreasing hair growth because it lowers your testosterone levels, androgen levels because of how it works hormonally. It increases the sex hormone binding globulin, and that takes down some of the free androgens. And also, so decreasing acne, decreasing hair growth. And also it keeps you cycling regularly. And you don't necessarily even have to have a period on the pill for it to be working to prevent the lining from building up. Because when you're on the pill, it reduces the endometrial buildup, right? So if you skip periods on the pill, or don't have much of a period, or have them every 3 months, that is totally safe and fine. It's safer to not have a period on the pill than on your own, not having a period. And I guess the next point I have that I would mention is, if patients don't like the side effects on the pill, there's other options. It doesn't mean you just don't have the discussion and ignore it and just never have the periods or have these erratic periods. The next thing I would say is, well, we have other options, right? Like the IUD is a great option. That is a very, the lowest hormonal birth control. And while that won't help, say, the acne or the hair growth or some of these other symptoms, it's not a very high level of hormones in your bloodstream. It's just progesterone at a very low level. And it mostly acts locally to keep the lining of the uterus thin, so you can prevent endometrial buildup, or hyperplasia, as we call it, and cancer. Another option, so if someone doesn't want birth control because their goal is to try to get pregnant either now or in the future, then another thing I sometimes offer is just a progesterone withdrawal intermittently. Make sure you're not pregnant. And then if you haven't had a period, and I say about 3 months, if you skip 3 cycles, you should really try to take a progesterone, take the progesterone and withdraw have a bleed. But, and I guess that takes me into, well, if someone has been trying to get pregnant, right, and they have not been able to, then, I mentioned earlier, if you've done the fertility workup, they will need to then do the full fertility workup, because we define infertility as over 1 year of trying to conceive without success. But depending on the age, I might sometimes initiate a workup earlier. Like if you're 30 and above, you don't have as much time to waste. Your fertility could be declining. So sometimes we initiate a workup after 6 months. And just because you have the diagnosis of PCOS doesn't mean you should assume that's it. That's your only problem. Because unfortunately, your partner could have a semen, sperm problem, and you could have other problems. So you still have to go through an infertility workup, which sometimes I do if they're young enough, and I'm not going to, delay them seeing a fertility specialist. And sometimes I refer if they're older. And then the treatments, if you've really established that it's just, it is likely PCOS, Clomid or clomiphene citrate is a medication that gynecologists will use to help these patients ovulate, and it has a pretty good success rate. But sometimes you may need more aggressive, injectable, you go through IVF, for example. So, did I answer that? Did I?
Yeah. Do you ever use the non-hormonal IUD for management?
You could, but you could, because it's not the most popular, but the fact that you have a copper device in the uterus, that it doesn't have hormones, but it does also cause the lining to not build up. It's not very popular, mostly because it ends up making patients, periods heavier and longer. But these patients that aren't really ovulating or even triggering a period, I think that would be helpful. I think it makes more sense that the Mirena is actively thinning the lining because of the progesterone, whereas the copper, I'd actually have to look that up, but my intuition tells me it should be okay. Should keep the lining from building up.
So the only reason I ask is because I hear this often that, any sort of hormone treatment makes me feel terrible. And and that's where I tend to rely a lot on my gyn colleagues, because all I can do, I'm not a proceduralist, so all I can do is say, okay, well, I have the option of the birth control pill, but all these other options, we've got to work through with their gynecology team to figure out, well, what's the best option for this person. So
right. And that's something I'd like to get to the root of sometimes, like why patients fear birth control, right? And you're taking a low level of hormones, but remember that your body is making hormones. You're not hormone free, at baseline.
Lot of fear around it though. Like this is, and sometimes, they'll choose to go without that. And, sometimes the weight management alone helps them regulate their periods, but not always. And my concern always goes back to, but like, what about the endometrial lining,
Right. I'm glad you're thinking about that because so I do agree that lots of patients patients can have side effects from birth control and they may want to, they can't take, there are patients that cannot take birth control of any type, but I do think there's also a lot of fear mongering going on out there about birth control. And I've even seen platforms of PCOS platforms where they're kind of poo-pooing birth control, but they're not talking about the endometrial lining. And that really upsets me. It's like, please tell them at least what, that this is something that they should worry about, and you could do the intermittent progesterone withdrawal. It's not birth control. It's not regular birth control.
Yeah, I'd love to. I'd love to
think about it.
This is, I think like that level of fear we're all sort of seeing. I think there's a lot of misinformation out there as well. And I think, it tends to feed off of like the last piece of misinformation, right? And then it gets bigger and bigger and takes a life of its own. But I think at the end of the day, it's really, really important that we stick to the evidence. And I always tell patients, this is what, the recommendations are. This is what we potentially see as a benefit. And I'm always willing to have the discussion of why, something is recommended over another. But, it's sometimes rough to see someone suffering, and because of the misinformation,
Right.
Yeah.
Okay, well, we have run out of time, but I would like to thank you so much. I think this was a great intro for patients. I've enjoyed talking to you. I'm going to, be able to be even smarter with these patients. Thanks to you.
This was very helpful for me as well. So I think it's actually really helpful to have kind of a multidisciplinary meeting as to the treatment of something we both see very often. So
yeah, why didn't I do this before? Anyway, anyway, thank you. I'm sure I'll be hitting you up with more questions, maybe about different topics in the future. Maybe I'll have you on again. Do you have any other closing thoughts before?
I think it's important, like if something feels off, bring it up to your doctor, right? Have that conversation, understand, what might be going on so that we can work through, all these things. And so again, it's not always a slam dunk diagnosis. And I think it's important to make sure that we do a thorough workup and, and it's not always a one size fits all approach either. So it's really, really important that we tailor therapy to the patient, their life, like all of that, right? The resources, everything, but it doesn't start until patients go and see their doctor. So, I mean, I'm glad that we're sort of, putting this on social media so that patients have access to an evidence-based conversation around a topic that there are lots and lots of forums and misinformation about. But I think, it's important to make sure that you're talking to a qualified individual to manage your health. So
thank you. So where can my audience find you if they want to follow your thoughts or,
yes, please feel free to follow me on Instagram on Disha Narang MD, and you can find me on Twitter or X as well.
Okay, with the same handle?
Yes.
Okay, Disha, I have a closing thought. PCOS is a condition that is often stigmatized because it causes symptoms that are judged pretty harshly by our patriarchal society. This leads women to feeling shame about their bodies and then have mental health struggles and delays diagnosis and treatment. But in the Gynarchy, we want to normalize this and other women's health conditions because they are common and simply part of being a human being. So down with the patriarchy and up with the Gynarchy. So thank you very much. Disha. Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.